So moving on to the epigastric view. In this view, we place the probe marker right into the epigastrium, as the view would suggest. And what you get to see in this view, the easiest things to identify are the aorta, the inferior vena cava, and the spine behind them, the vertebrae behind them. And so the vertebral body will form this bright line and then black behind it. So it's this big black area, which is just a shadow. The echoes from your probe they just bounce right off the spine, and they don't return from any deeper than the surface. And then you'll have the IVC and the aorta. And if you follow the aorta up cephalad and caudad a little bit, you can see where the superior mesenteric artery branches off. And when you see that superior mesenteric artery branching off, that's where you'll find the pancreas overlying that area where it branches off. And so this way you can locate the pancreas. Now rotating the probe so that the probe marker faces towards the head, we can get a longitudinal view of the great vessels. And the inferior vena cava is especially useful in this view, because this view allows you to see how collapsible the inferior vena cava is. So when you take a sniff, when you take a sniff in like that, you should see about 50% collapse. So the walls of the inferior vena cava should move towards each other to decrease the lumen size or the lumen diameter by about 50%. So you can see a more normal inferior vena cava here in this video, and then in this video it's very distended. It's really not collapsing much at all in this video. And so in a state like this, where there's very little collapse, you could draw one of several conclusions from that. You may have cardiogenic shock or pulmonary embolism or pulmonary hypertension. There's something preventing blood from being pulled out of that inferior vena cava by the heart. Or you may have a state of volume overload, perhaps. So perhaps you're flooding the person with too much IV fluid, for example. Conversely, if you have far too much collapse, if the walls approximate almost entirely, or if the walls are like kissing with each sniff or with each inhalation, then you can start to think about things like dehydration or perhaps sepsis or hemorrhage, things that are reducing the intravascular volume. So this is a very useful thing just on a day-to-day basis, especially when you're dealing with fluid management in people who have heart failure. In the epigastric view, you can also inspect the abdominal aorta. So this gentleman is sliding his probe from cranial to caudal and taking a transverse view as he does so, just scanning down the aorta down to its bifurcation to assess for any enlargement, so any aneurysm or dissections. Next, he will get the aorta in the center of his screen, and then he'll rotate his probe, keeping the aorta in the center of the screen. He'll rotate the probe until the probe marker is pointing towards the patient's head, and this will allow him to obtain a nice longitudinal view of that aorta. So you just want to see the nice tube running across your screen there, like this. And this is an example of what you might see if someone has a large aneurysm and then has some mural thrombus that has that has a patent canal running through it. So you see this is still the tube shape, that circular shape of the aorta, but then there's this this gray ring around a black center, and that gray ring is the thrombus, of course. And this is useful in everyday practice in primary care because the United States Preventative Services Task Force recommends at least once screening all men 65 to 75 years old who have ever smoked for a AAA. And this can be life-saving for some of your patients. If you turn the probe longitudinally down the aorta, you might see a view like this. And in this particular case, we can see some mural thrombus there again, marked with a TH. And then you can also see a dissection where there's an intimal flap that's separating from the wall of the aorta. Pointing our probe upward into from this epigastric view, if you sort of push your probe down firmly enough so that it can point up underneath of the ribs, then you can see another view of the heart. And this view may be the only view you get in someone who has significant COPD, because sometimes in COPD the lung just covers up the heart anteriorly and it pushes the heart down, and so as the diaphragm flattens out, and so it may be the only way that you can actually see the heart in someone with significant COPD. And in this in this view, you may be able to see a pericardial effusion, and this is actually the same place where you would make an incision in a surgery called where you would create a pericardial window, or a window between the pericardium and the pleural space to allow fluid to escape from the pericardium to prevent tamponade. So this is one example of where this would be immediately useful. You could figure out why this person is perhaps hypotensive and tachycardic, and then you'd know exactly what you need to do. You need to drain that. And so another example of something being where it shouldn't, here we see some air. This is from an 80-year-old female who was having some abdominal pain. And air is very reflective to the sound waves produced by the ultrasound probe. So when they initially placed the probe on her abdomen, they really didn't see any detail in her abdomen. They just saw this very white line, this very hyperechoic line, and then nothing. But when they pressed the probe harder into her abdomen, they pressed the air away from the probe, out of the way of the probe, and then suddenly were able to see abdominal structures, which tells them that there was air there. And just knowing that there is air in the abdomen is tremendously important. So this lady had pneumoperitoneum.